Hello, everybody. Welcome back to Health Record Systems and Issues. This portion of our lesson, we're going to talk about the content and structure of the health record. We have covered a little bit of this in previous classes. We're going to kind of give you an overview here, and then, excuse me, then we're going to go into a little more detail in our next segment, okay? Okay, this lesson is going to be a little different. We're going to, our learning objectives are going to be to understand the content of health records in various healthcare settings, to recognize the documentation requirements of accreditation organizations and state and federal government agencies, because we have a number of different ones out there that we have to meet in a healthcare facility. Next slide. Our key terms that I want you to kind of know about in this chapter would be accreditation, Accreditation Association for Ambulatory Healthcare. Wonder which type of records that would be for, right? An advanced directive, what is it? American Osteopathic Association. That's getting into more of the natural healing type things, right? Anesthesia report, authorization to disclose information, autopsy report, care plans, certification. These are all things that you're going to find in a health record. And the documentation does, I'm sorry, I meant to remove that chapter 3. Please ignore the chapter 3 at the top of the screen. We are obviously in chapter 4. Anyway, some of these terms and the requirements for documentation and content and different forms will vary in the setting of that health record. Okay, like the Commission on Accreditation of Rehabilitation Facilities, CARF, that's for rehab records. You see, and we had previously for ambulatory care records, okay? And then we have the computer-based patient record, the CPR. We have conditions for coverage, conditions of participation. We have a consent to treat form and what that involves, a consultation report, deemed status, a discharge summary, the electronic health record, the EHR, the electronic medical record, the EMR, expressed consent, hybrid health record. We've already talked about some of these, right? Imaging technology. Think about radiology, x-rays. Integrated health records, the Joint Commission on Accreditation of Healthcare Organizations, which is now just referred to as the Joint Commission, okay? But you need to know both of those terms, because whenever you're out there in the healthcare community, a lot of people still say JCO, and it's really now just the Joint Commission, okay? And if you're asked on an essay question on your next exam, perhaps, or in the future, The Joint Commission on Accreditation of Healthcare Organizations, parentheses, JCO, is now called, and you would say, the Joint Commission, and that "the" has to be in there, okay? Licensure, medical staff privileges, Medicare conditions of participation or conditions for coverage. I know that you can probably figure out what that's meant for, right? Medicare patients. Minimum data set, MDS, for long-term care. We've already worked with the UHDDS, the for hospitals, right? Uniform Hospital Discharge Data Set. We work with that in applied systems. And this particular one, MDS, minimum data set for long-term care, you can kind of figure that out, right? The National Committee for Quality Assurance, the NCQA, and you'll be hearing about these, all of these terms throughout the program, and you'll learn, you'll become more and more familiar with them and what they stand for and what they do. Operative report is just what it says. It's the report on an operation, right? Outcomes and assessment information set, OASIS. I believe that's palliative care. It's not coming through very well. Sometimes when you upload slides to Blackboard, it kind of shifts them around a little bit, so it makes it a little difficult to see. The pathology report, whenever anything is taken out of the body, it has to have a pathology report. Okay, if you remove a growth, a lesion, an organ, all of that, they have to have a pathology report for it to show what it was and if there is some type of problem with it. Patient assessment instrument, patient history questionnaire, patient self-determination act. What is that? PSDA. The patient's bill of rights, a personal health record. And I'm going to give you a little assignment on that at the conclusion of our lesson today. Physical examination report, physician's orders. Some of these I know you're pretty familiar with, right? A problem list. What type of record would you find a problem list in? A problem-oriented health records. Where would you find those? Progress notes. Those written by physicians, right? Or consultants, right? Okay. Recovery room report. Remember that if somebody has a procedure or an operation, they go into recovery. So that documentation is there and required. Resident assessment instrument. Resident assessment protocol. Source-oriented medical records. Transfer record. Where are they transferred to? Within the facility or outside the facility, as in going to another healthcare organization? Okay. So let's talk a little bit about health record formats. We are all pretty familiar with paper records. That's considered the traditional health record, right? Then we have computerized health record, where it's in a computer. They have parts that are scanned in. You know, there are some electronic, but it's kind of it's computerized. It's scanned in. It existed in paper, and then now it is scanned in so that you can see it on a computer. Okay, does that make sense? Excuse me. And there are facilities that have computerized patient records. An electronic health record is supposed to be just that. Everything's entered into it electronically. It is all kind of keyed in. Progress notes, everything is fed in. It doesn't exist. They don't use paper at all unless someone requests that it be printed. Okay? So you see the difference there. We have paper, then we have computerized paper records, computerized, yeah, computerized records, the CPR, and it used to be paper and it was scanned in. Then we have electronic health records that were never really paper, typed directly electronically into the system. And then we have a hybrid. And the hybrids are really what I think is the more common, because you have some things that are entered directly into the system, and then you have some other things that are kind of scanned in, right? So it's kind of a mixture. And you'll find that really a hybrid is kind of the more common, I think, in my personal opinion. Now, do all vendors know these distinctions? No. So you might hear them talk about a computerized record, an electronic health record, or a hybrid record. Usually it's a CPR, EHR, or EMR. They use those terms interchangeably, but we know the difference, right? Some of the uses of a health record, some of these we've already talked about. We have patient care and provider communication, right? We've talked about those. We have evaluation of care and performance improvement, where we have certain teams within our organization that review those records for quality of care to see if we can improve our performance, to do special studies in research. We've already talked about it being legal evidence of our care for that patient, right? And then we have the public health, where we report certain things to the Department of Health. And then we have the education of health professionals. Think about in a teaching institution such as UAMS. They have physicians, and they have nursing staff, they have radiologists, they have all different types, even dietary students going through their records. And they all have to go through special training and HIPAA training to learn about confidentiality and sign agreements and all of that, but they still have to learn about health records and health care through actually looking at actual cases, such as, okay, you will eventually be coding records as part of your overall education with our program. When you do so, you'll have confidentiality agreements, right? And you'll be going out there and perhaps coding in different situations or on clinical rotations. So again, they are used for the education of health professionals. They are also used for risk management. If something happened, how can we prevent it from happening again? They're used for organizational planning. When we're looking at health record components, we have clinical data and we have administrative data. And we need to know the difference of those. And we've already talked about these some. So part of this, I want you to remember that part of this, as we go forward, will be reviewing what we've already gone over, but we'll be adding a little bit more information each time. And like your exams, we'll have a few review questions scattered in there also. Next slide. So when we're talking about the health record, we also have standards, and we have different courses for those standards. We have practice needs. What is common in the practice of care? For instance, nursing. Nursing documentation is different than physician documentation, than a radiologist documentation, than lab documentation. You see where we're getting at? So it's whatever according to the practice needs and what's common and accepted in the practice for good care. We have facility guidelines. For instance, what do we require in our history and physical? What components? What formats? What standard do we have for our history and physicals? So we have those facility guidelines. Then we have licensure standards. If we're getting licensed by the Board of Health or the State Health Department or whatever, certification standards, accreditation standards. We've already talked about the Joint Commission, and they are really high. Did you know, though, all healthcare organizations do not belong to the Joint Commission? That's right, because you have to pay to do so and pay for them to come and look at your facility and kind of critique it, right? And make sure you're up to up to standards. They are like a gold status symbol. You know, if you pass Joint Commission standards, then you have met the minimum. You have met the minimum or exceeded their standards, and that's a very good thing. But again, it is optional, elective. Okay, so some smaller healthcare facilities, for example, may be very tight on their budget and not be able. They think that that money could be spent better in other ways. You know, established data sets. For instance, we've already talked about the Uniform Hospital Discharge Data Set. That's the minimum for a hospital that they have to collect, right? Next slide. There are different types of health records according to the healthcare setting. We have acute care, which would be like a hospital. We have emergency care for an emergency department. We have ambulatory care and ambulatory surgery. We have long-term care, we have home health, we have hospice, we have behavioral health, rehab, correctional facility. Yes, even prisons have their own types of health records. Actually, the program at UAMS had a student who went to work for a correctional facility in their health information management department. End-stage renal disease, that's a different type of record. And then we also have personal health records, the PHR. Next slide. Let's talk about the details of some of the different types of records we've mentioned. An acute care record has clinical data. Okay, talking about the clinical data, talking about the admitting diagnosis. What do they think? What brought that patient to the hospital in the first place? It's not necessarily the final diagnosis, because the final diagnosis is after study, okay? The principal diagnosis is after study, and we'll talk more about that. The admitting diagnosis is what brought them to the hospital now. What is our working diagnosis, okay? So you can tell maybe it's a mass, an abdominal mass would be the admitting diagnosis. But after study, meaning further testing and examination and all of that type of thing, the principal diagnosis, the discharge diagnosis, was a form of cancer. Okay, so you see how that different the admitting diagnosis is from the principal or discharge diagnosis. Medical history. If they had a family history of cancer, that would certainly be pertinent, right? Or a history of abdominal pain, or, you see where we're going with this. Physical examination. What were the findings when we looked at, examined the stomach and they palpated the stomach, meaning they pushed on it a little to see was there pain or if they could feel any masses. Clinical observations. Physician's orders. We know what those are, right? And then reports of diagnostic and therapeutic procedures. Therapeutic would be treatment, okay? And if you look at abbreviations, DX is diagnostic, and PX would be procedure, and TX would be treatment. I know, a little crazy, huh? Consultation reports would be in there if we had a special consult to come in and look at the patient. Obstetric and newborn reports. Those can be a little tricky, and you wouldn't think so, but remember that copies of the newborn's records will also, you'll find some of those in the mama's records. So you have to read very carefully and know which one is which. A discharge summary. That summarizes the patient's care. Then the patient instructions. What are they supposed to do when they discharge? Do they have certain medications? Do they have do they have wound care? Do they have a return visit scheduled? What are the patient instructions? A transfer record would exist if they were transferred to, let's say, a skilled nursing facility, which would be a SNF, or maybe they go to uh, a long-term care facility, or maybe a long-term acute care facility, or perhaps to a nursing home, nursing facility. They could be transferred to different, they might even be transferred to another acute care hospital where they have certain types of treatment, or maybe the patient is unhappy with their care and wants to go to a different facility. Or perhaps they're transferring the patient to by ambulance to a facility in their hometown. Okay, you see where we're getting at with a transfer report or record. That's different from transferring the patient from 3A to 4C, and we'll talk more about that. An autopsy report will also be in the record if the patient expires. We'll have a preliminary and then the final. Those are all for acute care. We might look also at medical history, content. We'll find the chief complaint. What, excuse me, what did the patient say when they came in? Why are they there? What did he present with? What was he complaining about? What did they say? The present illness. What is going on with that patient? The past medical history, the pertinent medical history. If that patient has a history of smoking 2 packs a day for 20 years, and then is complaining of chest pain or even or abdominal mass, then you're going to think perhaps that's pertinent because it could be cancer. And we all know that cigarette smoking contributes to or increases the risk for cancer. You see how looking at the past medical history, maybe the family history might also be there, because if there is a strong, maybe a woman is presenting with a mass in a breast, okay, then family medical history of breast cancer would certainly be important, correct? Review of systems, ROS, review of systems. That means the body systems. They're going to go through the body from top to bottom and kind of review it and see if there's anything that might be important. Physical examination content. You're going to have a general condition statement. They're going to go over the vital signs and note those. They're going to do the findings of the examination by body system. Head, ear, eyes, nose, and throat, abdominal, they're going to look at their blood, their different things like that. And then they're going to do their diagnosis and or impressions of what they found. Maybe the patient presented with chest pains and the body is clammy, okay? Or abdominal pain and the patient has a high fever, okay? You see where we're getting at with all the documentation. Next slide. Then we look at the diagnostic and therapeutic orders. We have an admission order. The patient cannot be admitted to the hospital without an admission order, okay? They can't just come up and say, hey, I'm here for a stay. A physician, an attending, has to write an admission order, okay? An order has to be written for all diagnostic and therapeutic interventions. So if they want to do x-rays, if they want to do lab tests, if they want to add medications, they all have to have a written order. Now, that can be typed into the system and use an electronic signature, but it has to be signed by a physician. Nurses, depending on their skills, such as uh, advanced practice nurse, can, if they have privileges at the facility, they can write prescriptions or write orders for certain prescriptions. Or a physician will have to. It's all according to who has um, privileges at the facility. And they have to be signed. If it's a verbal order on the phone, it still has to be signed by the physician, whether it's in writing um, or whether it's electronic signature, okay? A discharge order is always going to be there unless the patient leaves AMA. AMA means against medical advice, and that's important to know, against medical advice. Now, why would that be important? Well, maybe they decided to just up and leave. Well, they have to consider, if they're considering leaving without, against medical advice, they stand a chance of their bill not being paid by the insurance or something like that. So, I mean, it's a pretty big deal when a patient leaves AMA, okay? If they're not leaving AMA, then there must be a discharge order written for that patient. There are standing orders, maybe for a certain diagnosis. They always go through these routine tests and labs are automatically scheduled, okay? That would be standing orders. And there's usually kind of like a form or a template for those, and the physician would sign off on that. Then we have verbal or telephone orders that I've already talked about. I apologize for the little bark. I'm recording at home today, and my little dog seems to want to talk. Okay, clinical observations. You're going to find an admission note, and you're going to find authorized care provider notes. For example, whoever is caring for the patient, maybe the patient is having rehab or whatever, okay? And then the physician notes, things like that. You're going to have pre and post anesthesia notes, which means they be pre, meaning before anesthesia. They have to come in and write the note and talk to the patient and explain the anesthesia and the risk, right? And then post anesthesia notes, where the anesthesiologist comes back and evaluates the patient, and also in post-op evaluating them. Pre and post surgical notes. they will make, those will be in there. A discharge note will be in the record. A death note, if the patient expires, will be in the record. Assessments will also be in the record. For instance, nursing assessments or occupational therapy assessment, rehab assessment, physical therapy assessments, different things like that, and they will each have care plans. There will be vital signs records where you can see what their vital signs were as they were monitored throughout their stay. Medication records, what was ordered, when was it given, and by whom. Okay? And restraint records would also be if restraints were ordered, you know, where they have to sometimes restrain the patient so they won't pull out their IVs or do harm to themselves or others. There may be records of other monitors, such as maybe they're monitoring their heart or something like that. Next slide. Reports of diagnostic procedures. You're going to see laboratory tests, you're going to see pathology reports, and you're going to see scans and images of different things like that. Maybe there's even an ultrasound report in there, or maybe you might see pictures of different things. It's pretty common if there are, if a patient comes in, presents to the hospital for admission from a nursing home, perhaps they came in and they have decubitus ulcers that go deep, sometimes all the way through to the bone. And sometimes they will take pictures of those so that they can document how those ulcers are shrinking, and it also gives the facility some protection to show, hey, this was present on admission. We did not allow this to happen under our watch. Okay, so scans and images are sometimes very important. Monitors and tracings would be another one. Next slide. Consents. They can be implied or expressed. We have anesthesia records if anesthesia was given, right? These are reports of therapeutic procedures, okay? There's always a consent. If any type of anesthesia was given, there's going to be an anesthesia record. There's going to be an op report or report from the procedure, okay? And there's going to be a recovery room report if they went to an operating room for the procedure. Sometimes they do it at the bedside, and in that case there wouldn't be a recovery room report. A pathology report, as I said, if anything's taken out or removed from the patient's body, there's going to be a path report. Next slide. Consultation report. This is where we consult a specialist. This has pertinent information from the patient record review because they have to review that record to know what's going on with the patient, right? And then they're going to write up their pertinent information from that record review. They're going to have a report of their examination of the patient, and then they're going to have conclusions and their recommendations for care. The attending physician can either choose to accept those recommendations and go with that for the plan of care, or they can do otherwise. Okay? Next slide. Deliveries and newborns. As I said, these records can be a little bit confusing, so you have to really look at them closely. And when I first heard that, I was like, how in the world can you get a mama and a baby's record mixed up? There's definitely a difference there. But you'll be surprised at how much that happens. In the records, there's going to be a prenatal summary, okay? And there's going to be an admission evaluation. There's going to be a labor record. There's going to be a delivery record, including the patient's information. The patient, meaning the infant's information. And then there's going to be a postpartum care record. So prenatal, what does pre mean? Prior to, right? Pre. And then post would be after the delivery, okay? Now in the newborn record, you're going to see the birth history and what happened there. And you see birth history can be looking at that delivery record, including the infant information from the obstetric record, right? You're going to have the identification of the baby, and the mother and the baby's records are always kind of have copies there so that they can keep mothers and babies matched up to the correct ones, right? Then they have physical examination, any birthmarks or birth defects obvious that they have found or that they're looking for. Then they have the nursing care record for that infant, and they have special tests or treatment records for that infant. Now, let's go on to the next slide. The discharge summary or note. Some places call it a discharge summary, some call it a discharge note. This is the overview of the patient's illness. It tells about their hospital stay or wherever in that record. They have the summary of the treatment and the response to that treatment. So if they didn't respond to that treatment, it will be documented. If they gave them a certain type of medication and they had a reaction to it, that would be documented. If they had a procedure, that would be documented, and they would tell how the patient responded to the procedure, you know, that type of thing. Then a discharge condition, including a discharge diagnosis, which would be the final diagnosis. And then we have the follow-up instructions. Next slide. The transfer record or referral record. We have the review of the inpatient stay because they have to know what's going on while that patient was in our facility. We have the current status of the patient. We have the discharge and transfer orders because they can't transfer a patient to another facility without discharging them from our facility and writing a transfer order to that other facility. And then any instructions for that patient's care. Next slide. Documentation of a patient's death. You're going to have a death note written in that record. And you've probably seen them call the time of death, the date and time of death on like ER or any of those hospital shows, right? You'll see that, and then they write a death note summarizing uh, what they think might be a cause of death or whatever. An autopsy report and assigned authorization. There are certain times when an autopsy is required. And we will be going into those in further detail and the requirements for autopsies, okay? Not every death, I've got to add this, not every death is going to have an autopsy. For one, they are expensive to perform. There are certain situations where a family might request an autopsy, and then in that case, they will likely be billed for it, and that's made clear to them. If this is an unexpected death or suspicious death, or the patient died at home, different things like that, you would find an autopsy report, okay? Next slide. Administrative data is a little bit different. Remember, that was the clinical data. That's clinical means the care of the patient. Clinical, okay? Administrative data, that's the demographic and the financial information. It's the consent to treat, where they sign that consent form. It's a notice of privacy practice because we're required to do that, and they do audits. The health department, AFMC, whoever, different organizations will come in and do audits to be sure that you are giving the patient the notice of privacy practice. And it needs to be posted there. The advanced directives, you'll find that. That's administrative data. Acknowledgement of the patient's rights. Authorizations, consent to treat, authorization to release information or discuss the patient's information with family members or a certain person, authorization for different types of treatments, those types of things. Then there may be some other types of administrative information. Next slide. An emergency care record, you're going to see that there are different things that are required in an emergency, in the content of the emergency care record. For instance, we're going to find the patient identification, the time and means of arrival, meaning, okay, the patient came in at 10:05 p.m. It may be military time documented, it depends. And the means of arrival, did they walk in themselves? Were they ambulatory? Did they come by an ambulance? Were they, you see where we're coming, the means of arrival, where we're getting at there? History of illness and the injury, the physical findings, and the medications that were given, and then the conclusions. If there were any different types of results of treatments. If you did any treatments, there may be procedure and test results that are diagnostic. Um, the care prior to the arrival of the patient. Maybe they were in an automobile accident and had to be given CPR or something like that. So the care would be there. Any orders, clinical observations, all of that, and the conclusions of that emergency care. Was the patient discharged to home? Were they admitted to the hospital? Were they transferred to another facility? Did they leave against medical advice? That documentation would be there also. Next slide. So, what is an ambulatory care health record? Think of ambulatory. When you ambulate, you walk. Okay? So the patient can walk in and out. Is basically the thought behind an ambulatory care record. Okay? It's going to have the registration forms, it's going to have the problem list, it's going to have medication list, it's going to have a medical history, and of course a physical examination with those progress notes. It's going to have any consultation reports. It's going to have diagnostic test results. It's going to have copies. I see that this slide in the upload got a little crazy. It's going to have copies of records from other providers. It's going to have patient history questionnaires where you know how you go into an ambulatory care clinic and you have to answer all these questions, like do you have hypertension? Do you have any rashes? Do you have do you have a problem with migraines? Do you have headaches? Do you have this? Do you have that? That type of questionnaire. It's going to have flow charts, any correspondence that they have with other physicians or other facilities and the patients. For instance, maybe they wrote the patient and told them the results of the test or what they wanted them to do. It's going to have authorizations and consents for treatment. And that word advance, if you look in the left column at the bottom, that's supposed to be advanced directives. It just kind of broke it up on a different thing, which I think is really kind of crazy, but advanced directives. Next slide. An obstetric or gynecological care record. So what's that? Obstetric, think about a pregnant woman. Gynecology would be a woman's record for a female doctor. Or I say female doctor because that's what my mother always says. I'm going to the female doctor, or I need to go to the girly doc. It's kind of, it depends on the patient, But anyway, you get the idea. It's going to have a personal and family history. It's going to have medical history of that patient. Then they'll have the physical examination. Then it's going to have a treatment plan. It's going to have any laboratory or other test results. For instance, if that lady has a pap smear, those results would be documented in the record. Any type of patient instructions would be in that record. Now, of course, if it's an obstetric record, you're going to see those pre and postnatal records, right, will always be in there, and that documentation for those. Next slide. Pediatric care. So what does pediatric care mean? This is children. Typically, it depends on the organization. They're going to define pediatrics as 16 and under, or sometimes they will say 18 and under. So you have to kind of look at the and see how it's defined. Content of a pediatric record. Okay, remember this is a child. So if at all possible, we're going to try to keep all their records together in one place, right? You'd have the birth history, any past medical history. You'd have medication and other monitor records. For instance, they're going to monitor their growth, right? To make sure that they are growing there. They're going to have the personal, social, and family history. If the mother, for instance, was on heroin or something else whenever she was pregnant or when she delivered the baby, that would be pertinent, correct? Yeah. The nutritional history, the immunization record would be in there. The progress notes, review of systems, that go from the head to the foot. The growth and development record, so that we can see if this patient is large or obese for their age, or underweight, or in the expected range for growth and development. Next slide. So what is ambulatory surgical care record? Well, remember what ambulatory meant. You can walk in and walk out, right? Well, kind of. You walk in and you leave, okay? So the content of the ambulatory surgical care record, think about outpatient surgery, okay? You have the registration information, you have the surgical consent, you have recovery room records, of course, the anesthesia record. You're going to have the op report and the pathology report. There's going to be pre and post-op studies, right? The discharge diagnosis is going to be there. Any allergies that that patient has, or even abnormal drug reactions, you're going to have medical history and physical examination there, and you're going to have record of the instructions and any follow-up contacts that that patient is supposed to have. Perhaps they're supposed to follow up here in the clinic for post-op care, or with their family medical doctor, or maybe with a specialist. Maybe they also need to see their cardiologist because some type of problem happened during the procedure. All of that's going to be documented in that record, okay? Now you can see why we said that the requirements vary and what you're going to find and the type of forms. They vary just a little from setting to setting, don't they? Long-term care records. So we're talking about skilled nursing facilities, subacute care facilities, nursing facilities, intermediate care facilities, okay? Intermediate care facilities for mentally retarded or mentally challenged patients, should be the terminology. Assisted living facilities. Next slide. Long-term care records and their content. You're going to have the admission information, right? We always have to have that demographic information. We have a personal property list. We have history and physical and examination there. We've got any transfer records. Where did they come from? Where are they going to? We have legal records. Sometimes they are under someone else's care. So we'll have that legal record. We'll have medications and other records. We're going to have assessments, any type of monitoring. The RAI/MDS. What's an MDS? Minimum data set care plan and therapeutic record. We're going to have the diagnostic and therapeutic records. This is another slide that kind of went crazy, didn't it? The physician orders, we're going to have test results, consultations, and of course, a discharge summary. A long-term care facility is typically, their average length of stay is 30 days or longer. Okay, next slide. Home health care record. Yes, even with that, if they're cared for at home and an organization, a home health care organization, send someone to monitor them and take care of them, that is also has required documentation. Have the admission information and care, right? The OASIS plan of care. And then we have the service agreement. We have the case conference notes. That's where different people are brought in on the case and, you know, they may have physical therapy, occupational therapy, personal care therapy, whatever everyone decides, the physician decides, and everyone comes together as a team, and all those case conference notes are in there. The certification and plan of treatment information there. The legal documents and the transfer information. The physician orders and referral information are there. And then we have the visit documentation and the discharge summary. Next slide. Hospice care record. This is the content of the hospice record. It's very similar in content to the home health care, but there is a difference there, okay? It's going to have admission information. It's going to have assessments and plan of care and that supporting document. It's going to have care plan reviews. It's going to have progress notes and special monitors for medication, for example. And it's going to have the discharge or death documentation, and then it's going to have the bereavement documentation. So you see we have some that's a little bit different. Hospice is typically more long-term care where the patient is expected to be terminal. Not always. It's sometimes they have, for instance, a member of my family was very, very sick in the hospital for many, many months, and she was transferred to hospice care, but only so that she could have ongoing treatment, um, and for long term. And she was expected to live. It's just that she was too ill to be just sent home and too ill for a um, just a nursing facility. She had to have special wound care and medications and all of that that was too much for that type of environment, so they sent her to hospice care. Now, typically, when you think of hospice care, you think of someone who is going for more palliative care. That's where they're trying to keep them comfortable until they expire. Maybe they do special um, treatments, try to keep their pain under control, and they also help work with the family and help prepare not only the patient but the patient's family and friends for um, when that patient expires, what they can expect in the future a little more, and how to prepare themselves. And sometimes, if you know what's coming, you can deal with it a little bit better and know, okay, this is to be expected, and it makes you feel a little bit better. They are amazing, amazing people. I don't think that I could do that type of work, but I certainly have a lot of respect for anyone who works in hospice care. Next slide. A behavioral health record. This is where we're looking at maybe psychiatric facility, okay? It's going to have the admission information and the assessments. It's going to have referral information. Who referred that patient to the behavioral health care facility? It's going to have psychiatric evaluations. It's going to have the patient's legal status. Um, are they of age? Are they an adult? Are they uh, a child? If so, who has custody of that child? Okay. Um, it's going to have treatment plan and the updates and the consents. It's going to have a psychiatric diagnosis or diagnoses that may be more than one diagnosis, progress notes, and the psychiatric history. It's also going to have any procedures documented in there, and it's going to have a history and physical documentation. Next slide. The behavioral health care record will also have the case conference notes, where the team comes together and discusses that patient's care and their discharge plan and that type of thing. The consultations would be in there. Any summary of that. Information on any unusual occurrences would be in there. The follow-up care plan would also be in there. The post-treatment plan would be in there, and any correspondence that they send to, for instance, if they are going to follow up with a psychiatrist on an outpatient basis, then that correspondence would be there, etc. Next slide. So what is rehab or rehabilitation or rehabilitative care records? This is where the patient is going to have an admission form, and you're going to see problems and goals and prognosis. Prognosis is how is this patient expected to do? Okay, it's going to have referral information. Who referred that patient to the rehab facility? It's going to have a history, including a functional history, and it's going to have disability and functional diagnosis reports. And there's going to be service referrals, there's going to be consultation in there, there's going to be any testing and treatment in there, and those reports will be included. It's going to have the PAI assessments, and it's also going to have any reports that are including orthotics or prosthetics. If they are, for instance, learning to walk, they've had a leg amputated, and now they have prosthesis or something, and learning to use it. All of that's going to be documented in the record. Next slide. They're also going to have the documentation of the program. It's going to have the program and the service manager plans. It's going to have the documentation of the patient or family participation in the decisions. It's going to have progress notes and correspondence. It's going to have any releases in there, release of information, those types of things. It's going to have evaluation reports, a discharge summary, staff conference reports, and follow-up care reports. Next slide. So a correctional facility care record. Correctional facility, these are prison records, those types of things, okay? They are going to have a history and physical. They are going to have progress notes. They're going to have chest x-ray and laboratory test results. They're going to have physician orders and medication records that are both prescribed and OTC, meaning over the counter. Any type of medication given to that prisoner would be in that record. A dental examination and psychiatric examination would be documented in that record. End-stage renal disease service records. They have some special requirements and documentation. So these are patients who have kidney disease that's in the final stages, okay, the end stage. And it's going to have admission information, and it's going to have the patient rights and consents. It's going to have the assessments. It's going to have the plan of care. It's going to have dialysis records and dosages. It's going to have progress notes. It's going to have the laboratory test results, and it's going to have a record of patient education and training so that they can know how to care for themselves. Next slide. A personal health record is one that is created by the patient, okay? So this is going to have your personal demographics, like where you live and those types of things. It's going to have your general medical information, like do you have a history of uh, fractures? Um, have you had surgeries? It's going to list all of your medications, your current medications. Sometimes it's important to know what you were treated with in the past. For example, how often have you had steroid treatments and things like that. So just keeping an ongoing record of those medications. Um, and when they started and when they were discontinued, you're going to have your immunization record, your allergies and drug sensitivities, any clinical test results, pregnancy history, conditions that you have, information from different care providers, your hospitalization records. When a personal health record is created, it may have been created by or started by your parent, for example. Or maybe you've started one for your children. And every time you take them to the doctor, get their immunizations or anything like that, it all goes into a notebook or a file, or you keep it documented online, or maybe you keep it electronically. This is your personal copies. I had an uncle before the personal health record was actually labeled as such and became a thing. He kept all the medical records for himself and for my aunt in two different notebooks. They each had one, and every time they went to the doctor or they had test results or labs or medications or anything, he kept it in this 3-ring binder. So, and every time they would see a physician, their family physician or a specialist, they would take that with them so that um, the doctor could see exactly what had been going on. And it prevented them having to go through test duplications and different things like that. So a personal health record is not always going to have everything in it. It's got to start somewhere. Maybe you're starting yours today, and from today forward, you'll find that when you try to set up a personal health record, you are collecting information from various sources. And you just kind of have to build it in, okay? And you can collect that information and you can keep it in a notebook. That's a personal health record, or you keep it online and using a free software, or you can even use special services where you can pay for them to keep them online and have it encrypted and those types of things. Next slide. Some other things you might want in a personal health record would be the personal, family, occupational, and environmental history, health plans and goals, health status, documentation of organ donation or durable power of attorney or advance directives. For instance, do they have DNR? Do not resuscitate. Those types of things. Charges paid for services provided. Health insurance information. Provider directory might have all their physicians listed and their contact information. Okay? Again, these are not specific requirements, but things you might find in a personal health record. Okay? Next slide. So, one of your homework assignments for this week is to visit AHIMA, the AHIMA website. That's the American Health Information Management Association website for more information about my PHR, or just key in personal health records. And then we're going to have a couple of questions, just I should say several questions that I'll post in a brief quiz so that you can answer those. And then we'll also get on to, and I do say brief quiz because it's to make sure that you did actually go and check it out. And then there's going to be another assignment. Okay? With that said, that's going to conclude our lesson for today.